Welcome to Decision Lab, a Beyond Prostate Cancer series where we explore the choices, trade-offs, and critical decisions that shape the prostate cancer journey. Decision Lab is where prostate cancer decisions are examined through the lens of evidence, experience, and quality of life. Through conversations with leading experts and patients, we help you better understand your options so you can make informed decisions with confidence.
Paul, many of our viewers, for example, they may hear the word equivalent disease control being talked about and wonder what that really means in practice. How would you explain that?
Well, there are a lot of layers to that, and the first two, which can be measured very quickly, when I say quickly, within 1 to 2 months, is what every prostate cancer patient is thinking about, is PSA level. And that's just one barometer, but it's one that is easily measured and which patients appreciate. And the other is testosterone level. So we know for decades that if one can produce a castrate T level, that prostate cancer for some period of time will stay silent. And we know that almost always a fall in PSA, and the steeper and the greater the fall, the better the response to whatever is being delivered. So those two relatively simple measurements are available to the physician and the patient straight away in the first month or two. And the patch trial showed that transdermal estradiol drops the PSA and the testosterone at the same rate and depth as does the LHRH analog that it was being compared to. Yeah. Now, we'll say where the rubber meets the road is, as Richard was saying, disease control not only by imaging, but by life expectancy. So the unhappy endpoint of death from disease. Now, you measure other endpoints before that, how long it takes to become metastatic, how long it takes to be metastatic and castration resistant, because they have been shown to not predict, but to be, we'll say, surrogates for the critical endpoint of how long will you live or when will the cancer cause your death. And the patch trial has shown that the PSA and the testosterone, as I mentioned, marches in lockstep with the traditional therapy, and that the metastasis-free interval, as measured by imaging, and here we're in a whole new ballgame with PSMA PET scans. This is conventional imaging, which we've used as our benchmark for decades, is equivalent. And as Richard mentioned, a survival, because it always takes longer to do survival studies because you're following patients until they die. And honestly, the longer it takes, the better it is, because patients are surviving that much longer to reach that endpoint. That will probably appear in the next 12 to 24 months. But all the steps up till that, we'll say, absolute critical and final endpoint have met the equivalence of what we have available currently. And I'll just add what Richard said about the finances. You'll never see an ad on TV or in the Super Bowl or in college football timeout about estrogen. You'll see it about all other medications because the pharmaceutical industry is paying for those ads and putting them to the public. But no one has the finances to do that for estrogen because there's no return on investment. So that's an issue that is sounds like it shouldn't be critical, but it certainly is.
I want to go back to, I want to add just one thing about the patch study,
Sure.
because this is something that I would understand, and I think most patients probably would now. So explain to them, the patch study originally was telling us. I published one paper with them, the quality of life paper, and so I knew their leads, and they were telling me going back 2.5 years ago that they envisioned having their paper done within 6 months. And then it was another 6 months. And then it was another 6 months. And I knew that the longer a survival comparison between two drugs, and their standard LHRH drug happened to be what we call in North America Lupron. They were using Lucrin, same drug, different name. As long as it kept on going, you knew the survival had to be the same, because you're trying to look for the two lines to split. And because the study was running longer, it affirmed 2 years ahead of time that they were going to get positive results. So I was aware of that, but I was being told we haven't seen anything published. So the patch study, and it ran something like 14 years. It's still running because they now have more advanced patients. They're now looking at it estradiol in collaboration with a doublet second agent and so forth. And also when they started, if you guess, well, they didn't have PSMA scans. No, they didn't exist back then. I mean, it started so long ago that there was no way of doing the better imaging. So it's had to change through the time, and there'll be a couple more papers out, but it's a fantastic study.
It's interesting. Richard brought up PSMA PET scan, because when I was diagnosed with recurrence, my oncologist, PSMA PET scan in Georgia, Emory Hospital, was in trial study. And he had suggested that I go for that trial study. And at that time, I didn't know what to expect. I'm like, okay, what is this thing gonna do for me? Am I gonna grow a third eye, if you will? Because part of this conversation, because that's where I had found myself, right? Quality of life. How will I live with this treatment? So if we're talking about estradiol, for example, because the first question I would ask myself, and part of it is also because my father, as I mentioned to you gentlemen before, passed away from stage 4 prostate cancer, right? But what the question I would find myself asking was, okay, how do we deal with fatigue? How do we deal with depression, sleep, hot flash, bone health we've mentioned here, sexual health, overall energy, the list goes on and on and on. How do you guys answer that question?
I will just say I can give you a therapy, namely a patch or several patches, that will control your disease equally well, but for everything you described, if that patient is having those symptoms, they will come back a month later and not only shake your hand, but hug you, and their significant other, their daughters, will do the same.
Which is profound, and that's something we want to look at further, because none of the standard drugs can say, oh, listen, not only does the patient feel better, but the partner feels better. And we have reason to think that if the patient feels better and is attentive to the partner will feel better. And we look forward to doing some research in that area. As for the fatigue, the brain fog, the hot flashes, hot flashes that happen at night, it can cause insomnia or wake up your sleep. And within a lot of your cancer, depression, insomnia, and fatigue come together. And it turns out mechanistically, there's a reason they can come together with standard ADT. If you're not sleeping well, okay, you're going to have fatigue. If you have the fatigue, you could get depressed. And any way you want to look at these three features come together, and it turns out, we know from the rats work and our own experience that the estradiol can beat that trio. You know, if you're not having hot flashes at night, you're going to sleep better. If you actually think of implications to partners, if you have a partner in the same bed with you and you're not waking up, going to the bathroom, or having hot flashes, they're going to sleep better, and they're going to have less fatigue and less depression. So these are profoundly clear benefits. But as Paul said, we ain't going to see ads for them on TV.
Yeah, Jack, if I can also say, now we are doing so much better with our new drugs, extending life, and the patients are living longer. So they are now going to have the opportunity to feel better during that increased interval of survival. And there have been papers that Richard and I have seen in the past year that have emphasized quality as much as quantity, especially as men get into the, we'll say 70, 75, octogenarian. I mean, every little bit of help to feel better is very welcome. And to be able to deliver that at no expense to disease control is something to applaud.
Yeah. And based on the conversation we're having, it seems like there is still a lot of skepticism out there. It's like, here we know we have a drug that works, but it's not welcome. Do you think this is something because more education is needed? I'll start with you, Paul, and then Richard, you can chime in. Where our doctors need to be better educated?
Yes. I mean, the education about estrogen, certainly in the male sphere and even in the female sphere, has been, I'll say, distorted based on past history. Oral synthetic estrogen DES, which produced all of these bad and sometimes fatal side effects. So, I mean, there is that past history. The shadows will say that estrogen, quotes unquote, has dwelled in. So you have to get past that. But then we have now a routine that physicians have developed over the years with regard to the various drugs, the bone protective agents, the labs that are necessary to follow, and their system is very programmed, and appropriately so if you're using those drugs, because you want to follow DEXA, you want to follow your liver and renal function and your calcium levels. So you have to have a good program. And the estrogen kind of interrupts that flow and is, I'll say, disturbing to the status quo.
I'll go one step further. I mean, the newest primary drug that's getting such a huge amount on the market is Orgovyx, because of patients showing up with advanced disease. One, you want to crash the testosterone quickly, and it does. And secondly, it's an oral pill and doesn't require injections. So a lot of patients are going on it. The problem is the side effects come on brutally fast. There's no less side effects than all the other drugs. And another part of my life is to help patients manage the side effects of those standard drugs, including Orgovyx, by getting them educated ahead of time. And we can't get to those patients. They're already on Orgovyx before they even hear about our class. So the timing is bad for that. But one of the things we found is those patients have more side effects than the ones on estrogen. The estrogen patients don't complain about the side effects. Those on Orgovyx do, but they're afraid to go off it because they had perhaps symptoms from their cancer ahead of time. They were aware the drug is working because they had so many side effects, and they're willing to suffer through. So we never expected that we'd have to try to sell this to the patients. And you started with, what do the doctors need to know? What do the patients need to know? And it's a funny part about his piece of history here with our Estradiol initiative, because I actually started working with Bob Watson, and I said, we're not really reaching the patients. We're going to have to get to the doctors. But I was also talking with Paul, and Paul said, we're not really reaching the doctors. We've got to reach the patients. And that was a moment of starting the Estradiol initiative. And there's a need at both levels for education everywhere here.
So
Paul,
is this part of more establishing a standard? Because we hear all these industry guidelines, NCCN, so on and so forth. Is that where the roadblock is today?
Well, there is a roadblock there because standard of care is important, and it's determined by a randomized controlled trial, the highest level of scientific evidence to drive clinical care, and the patch trial fulfills all of the criteria of that highest level of evidence. And Richard and I are convinced, because all other RCTs that have been analogous to this in other cancers and other therapies get to the guideline. And then that gives the physician not only permission, but security that he is following not some tangent, and like Richard and I were N of 1 or N of 2, he's following the best that medicine can provide with regard to what's real and what's appropriate. So getting on the guideline algorithm is very important, and we are awaiting that with bated breath.
Wow. Richard, you are going to add something.
Well, I just simply say, yes, is that the barrier? No, that's the big problem. That's just one barrier. I mean, we still need products, and FDA will not arbitrarily license transdermal estradiol. That's the molecule. You need a drug company coming forward to say, if you give us approval to sell it, we'll sell it. Okay, and that's one of the things that we didn't envision would be a problem. The fact that none of the drug companies are interested, particularly none of the major drug companies, because it's too damn cheap to be worth it for them, it was a shocking discovery.
Is this? I'm sorry for cutting you off, but I wanted to make sure I capture. Is this something that, or how should patient present off-label options?
Very quietly and patiently, with information. The New England Journal, I mean, that is the Bible of medical practice. If that's, and it's been that way, it's in stone, so to speak, as a very reliable conveyor of medical education, but recognize that the doc is going to be somewhat not suspicious, but I'll say less than enthusiastic, and you have to kind of make your own case quietly, but convincingly with the evidence in hand.
On our Estradiol Initiative, people go to the site estradiolinitiative.org. It's what Estradiol Initiative is, as if it's one word.
Yeah.
We have a portal where they can ask questions, and we're getting them. And the question you ask is, how do I get my doctor to approve it? And I will refine what Paul said, because I end up talking to these patients typically. Don't go in with a pile of papers and expect the doctor to read them. You don't even have to go with the New England Journal of Medicine. They're MDs. They can pull up that paper. Go in with the first page and say, I don't know if you read this. I've looked at this. Could I try it? And then be quiet. But I mean, if you're going there and you're spending a half hour talking about how miserable you are on Eligard or Orgovyx, you're just going to burden the doctor. In one of our surveys that we've recently published, Paul asked a brilliant question, because this is where we're working with the physicians and the patients. He said, and Paul, I say this all the time, but I'm not to you. He added the question, how many doctors will you go to estradiol if the first doctor declines? And the patients who have learned about it, they will say, well, I'll go to this. I mean, some of them are saying, I'll go to 2 or more, or 3 or 4. Yeah. And that sends a message to the doctors. If you don't accept this and it's off label, Don't expect the patient to go away happy. They're going to simply bother another doctor, which is going to be a major cost on the healthcare system for both the patients and the doctors. This was a moment when Paul said, we want to add that to our survey. I thought, oh, that's brilliant. But it also shows how we have to be working at both levels to realize to make this a go, it's got to be manageable for both the patients and the physicians. And if it's going to be too complicated, then it's going to be a no-go.
Paul, anything you want to add?
No, I think that's well said. And as I say, polite persistence.
Wow. So one of the things I like to do is, okay, we know where we are today. We also, as scientists, as doctors, you guys always have to look into the future, right? If we were to have this conversation, let's say 5 years from now, what would success look like to you? I'll start with you, Paul.
That every patient that is appropriate for androgen deprivation therapy hears from the physician a balanced explanation of the options available and is amenable to the patient's direction towards which they would prefer. And I will say, because in my mind, the scale is so tilted one way, I would hope that of 100 of such interactions, 85+% will be receiving transdermal estradiol as their ADT option.
And it's available worldwide.
Yeah.
I mean, that would be certainly, I mean, what I was amused by the thought about what could I imagine in 5 years from now is that I want to go back to my history. I mean, I started in paleontology, not going to help anybody. I studied bizarre things that animals do in weightlessness, not going to help anybody. I studied details of their feeding mechanics of tadpoles, their swimming mechanics and modeling of that. And I have a project with colleagues in Australia on some really, really bizarre tadpoles. So for me, I think success would be, one, it's cheap, available, and used worldwide. And I'm back to studying tadpoles.
Wow. Back to studying. Okay,
Yeah.
so Richard, let me then ask you this follow-up question. What is one misconception about prostate cancer? Coming from both the scientific world and a patient yourself.
One misconception. There's a bunch of them. A huge number of patients do have either understandable an excessive fear of being going into treatment, or they have, as you have watched your dad go through it. A lot of patients don't know how people die of prostate cancer, and that's sad. On the other hand, you have patients who are so afraid of the advancing of prostate cancer, and they've heard somewhere that, ADT only is good for 3 to 5 years, that I've seen this, I'm going to delay starting ADT because I'm afraid that it will put me on a pathway for which this will fail. So I'll wait to the last minute before I try a treatment. So I'm seeing both ends of it. I think one of the biggest mistakes I've seen is not being realistic about it. Either too panicky, and then you have people who vow they're never going to go on treatment. Some of them found their way to estradiol, by the way. Or those who, I mean, I can think of such sadness. A patient this was in Canada, a patient who his wife had hepatic liver cancer and went through chemo, and it was very, very rough. And he vowed that he would never go on chemo for prostate cancer. And he may be dead now. Wow. I have seen patients who are so desperate to know where their cancer was. And this is also true. And I know this person is dead. He was in Washington State. I've been a guest in his house. He needed to know exactly where the tumors were. And so he went off of the ADT in order to be sure that the tumor was large enough that they could image it. And I'm thinking these are bad understandings. So there's a lot of not knowing the whole history or being biased by the experiences that you individually have. And both of them are things that can lead to misconceptions about proper care and treatment that can maximize both quality and quantity of life. That was a very general answer, but again, before you jump in, Paul, was that fair?
Yeah, that's fair. I think fear is an overwhelming factor. Folks will get heart disease and they'll go on their diet and their exercise program and feel kind of going forward with their heart in a positive direction. But cancer is the alien. It's a battle. It's time, energy consuming, and you don't learn to live well with it. And I always think of Mukherjee's statement. He wrote The Emperor of All Maladies. He said, in order to win the war against cancer, we have to redefine the meaning of victory. And that is the ability not only to extend life, but to have good life in the extension.
Wow. So as we're getting ready to close this conversation, you both have lived this journey as experts and patients. What message would you like to leave every physician treating prostate cancer to hear on one end? And at the same time, what message would you like the patient to hear? I can start with you, Richard.
I think there's a huge push towards shared decision making, and Paul and I are big fans of it. And what are the biases and what not all the biases? What are the preferences of the patient? The patient has their own agency, assuming they're not cognitively impaired in a substantive way. And if the patients are given alternatives, when the doctor should listen. That's easy to say, but what's also I think important, it hasn't been added enough to the conversation, is if the patient says, I really want to do estradiol, it is worth asking another question. What experience do you have with it? Or what have you heard about it? Because patients often, unfortunately, like when I mentioned his wife had died of hepatic cancer and decided therefore all chemo for all patients, for all cancers was terrible and was deadly and nobody could survive chemo. This shows how bias plays. So I think we got to get better informed. I think this will happen without taking up more clinical time, because the AIs will help patients. The doctors will say, please send me these 5 answers, these 5 questions. What is your experience? What are your concerns? And get that up front. I think it can be done efficiently, but we're not there yet. And I don't think a lot of patients realize that in giving respect to their opinion in the clinical setting, is not the same thing as giving them the best advice, because if you don't know where they got their opinion from, you're not really digging deep enough.
Yes, I encourage patients, and I always did when I was in practice, is to start doing homework, to learn as much as they can about the situation. Granted, there's more there than they could possibly absorb, but to get some idea of the playing field of the therapies, and to not be so fearful that they must act immediately just for the purpose of action. And with prostate cancer, not all cancers, but prostate cancer specifically, time is on the patient's side to weigh the various options and to give them thought, because in my experience and that of others, the most dissatisfied patient is the one who insists on something immediately to be done because they are just hyper anxious that immediacy is important. Time is on their side.
Right. And also they all should realize that there's so many chat lists. Reluctant Brotherhood is interesting in that regard because it leans on the emotional side, not on the treatment side. But if you go, some of the chat lists, you can say, I've been offered this drug combination. Does anybody have any experience with that? No, the people who have had experiences with it and doing fine are on the chat lists.
Yeah.
So that is the people who are the chat lists, the people who had the bad experiences, and understanding what is a biased sample and what is an adequate sample. That's a very big part of science, and that's not the particular way that the average patient works. But to give the patient a chance to express their opinion without knowing where they got their opinion and what biases they got is a big problem. And I'm hoping that we'll be able to get that into the healthcare system in a more convenient and efficient fashion. AIs are helping. AIs are improving communication between doctors and patients, as well as advancing diagnostics for image recognition and so forth on radiographs and slides and so forth. But you can also rely on it. I'm seeing on some of the chat lists patients saying, "Oh, you asked this question, I fed it to AI," and then they give me two, 3, 4 pages of information, which is also again noise. But at least if the patients say, "I read this on ChatGPT," at least the doctors will know where the patients got their biases.
It's interesting you brought up. First of all, it seems like this conversation we could go on and on and on, because there's a lot of areas that we didn't touch that I think would be very beneficial for our viewers as we educate men who are facing prostate cancer. But I'm saying that because one of the things, Richard, often members of the reluctant brotherhood or patient would walk into their doctor's office and say, "Well, ChatGPT told me this is something, or this is what I need to do. This is what I want you to do because ChatGPT told me that's the right answer." How do we handle that?
Oh, it's a field that's evolving daily or weekly. It's so fast. I mean, there's no longer one AI. Paul uses one that the doctors have, which is damn good. I use one that the scientists like because it gives me all of the references, but nobody would want to read that. But it could be very good. I think what's happening already is the doctors can say, "Well, let me check it on another source," right in the office, and it doesn't have to take a lot of time, because we're getting to a point where it isn't wrong for the doctor to say, "I'll dig for that. Let's wait a minute. Let me click up through it. Let me see whether we come up with the same answer from these other sources." Again, this is an issue about sample size. Yeah. I mean, ChatGPT is still just one sample size, and there's going to be a shakedown. We're getting a proliferation of AI tools. But a model that I heard was, if you go back to the 1920s, the number of car models that were coming out of the United States are far more than we have now, because the industries didn't survive. So there'll be consolidation. It's very fast evolving. But I think the main question, like the clinician might say, and Paul's a clinician, I'm not, is let me take a look at that. That's interesting, I think, but let's see if I can dig a little deeper with you here now. And then we have joint decision making. And hopefully it won't take a lot of time, and hopefully the doctors and the patients will both feel that they're working with strong data. But I would not, any advice I might give you on this or suggesting what might happen this week will probably be different in a month's time.
Paul, anything you want to add to that in closing?
Just that the different AI models I look at as a second opinion. We often, as physicians, encourage second opinions to check what we think. And this is a more rapid way of doing that. And so it adds to the body of evidence to help direction of therapy.
Well, there you have it, folks. Today's presentation, today's discussion has been with Dr. Paul Schellhammer and Richard Wassersug. Gentlemen, I want to thank you very much for being part of this conversation. I am leaving an open door for you to come back anytime, because I feel this is a movement that we really need to talk at the grassroots level as well as the pharmaceutical level, if you will, or the clinical level. As we usually say on this show to our viewers, until then, take care of yourself and take care of each other.
Thank you.
Thank you.